It's like, okay. So roll into the ER, and I'm sitting there, and I'm a paramedic student at the time. Derek was being the amazing preceptor, had an amazing other partner with us.
I don't remember this.
This was good. And so this made, so I didn't do well in my OR rotations. I didn't get all my intubations the first OR rotation. So I had like one intubation left that I had to get. So like, there in Florence, the hospital is like, you just roll in with the ER doc and be like, hey, we're gonna intubate somebody, can I do it? And it's like, oh yeah, sweet. So long story short, we got this like, she's probably late 20s, early 30s, female, totally faking like she's having like an overdose thing. It's like very dramatic, blah, blah, blah. We bag her for a while, then we stop, and it's just going up and down, up and down. Finally, the doc comes up, he's like, hey, I'm gonna intubate this gal. You wanna come in? Reese.
Oh.
Yeah. So they're getting ready to intubate, and he's just like, hey, you're gonna want to be part of this. I'm like, all right, cool, let's do this. I'm just a paramedic student just like you guys. I mean, doctor tells you, hey, we're gonna do this. You just, yeah, let's do this. And so like, we're getting all the meds ready and everything. What's he do? He draws up sucks and only sucks. And he walks up to her, and I'm standing there ready to intubate, very eager, and he's like, so, whispers into her ear, he goes, this is what I'm going to do. I'm gonna give you 5 seconds to stop faking, and then I'm going to eliminate your ability to breathe. You will be conscious, and you will know what's going on around you, but you will not be able to breathe. He goes, I'm going to give you 5 seconds. I'm like, you're gonna do what?
So unethical.
Yeah, I mean, needless to say, this guy's not an ER doc anymore. But I'm just like, you're gonna do what? I'm like, we just went over this airway stuff. I was like, you can't do that. I was like, I need to, percent. I'm like, I'm just like freaking out in my head. He's just like, all right, you ready to intubate? I'm like, yes, sir. Yeah. He's like,
Which morbidly, I would love to know what it's like to be paralyzed. Now.
I would not.
I would.
I think I'm just morbidly, just knowing that somebody's there.
Are you the type of person who wants to also know what it's like to be tased and things?
A defibrillator, yes.
He defibrillates himself on accident sometimes. So, long story short, he's like, all right, here we go. And 5, 4, 3, 2, and he goes, last chance. Nothing. Like, you see a little flicker on the eyelids, and he's like, okie doke.
Stubborn.
Slams her with sucks. And I'm like, I'm ready to go. And he's just like, no, just wait. I'm like, no. That is not how we work around here. I was like, sucks goes in, she's paralyzed, I do my thing. He's like, no, just wait. He's like, he leans up, he's like, I bet you wish you would have woke up, huh? And he's like, okay, paramedic student that's never done this before, go ahead and try and get an airway on this. I'm like, ugh! So I'm, of course, freaking out.
As long as you didn't use your name, that's fine.
Right, I know. The best part was, like, I got in there, I was like, oh, like pearly gates wide open. He was like, yes, I'm gonna get this tube. I passed the tube, did everything set, and he's just like, I'm like, thinking, okay, here we go. We're gonna do some Versed now. And he's like, he goes, so what should we do now? I'm like, so post sedation stuff. He's like, right. He goes, what would we normally do? I go, I would go with Versed, some Vec, because it was Vec back then. And he's just like, right, that's what we would normally do. I'm like, yeah. He goes, I go, so should we do Versed? He's like, no. I'm like, okay. He's like, yeah, we're just gonna let this go for a little while. I'm like, okay. So what do you think he did? Doubled up the sucks dose the second time. He's like, oh, we're gonna give one more dose of sucks. Oh, let's just make this drawn out.
You guys are breathing for it, right?
Yes, we're.
Okay, thank you.
I tubed. Remember, I tubed. I got the tube.
You didn't say that you were breathing.
And so yeah, so eventually they end up putting her. They didn't give her Versed. They put her on a sedative, non-amnesic, sent her to the ICU for a little while. They extubated her the next day.
Tordal.
Yeah, Tordal. And never heard anything after that about any sort of repercussions or anything like that. But it's one of those things. It's just like, okay, we do things for a reason because we don't want to be on the receiving end of, hey, I remembered everything that you talked about in the back of the ambulance while you were intubating me. We don't want that kind of thing because a lot of times we're joking around because we're stressed and that's how we deal with things. And so yeah, so always give post-sedation meds because it's good, right?
Can I tell another post-sedation med?
Sure.
So I had this patient, she was a probably 56-year-old female, and she had a massive head bleed, spontaneous eruption of an aneurysm. tried to intubate, went through my whole RSI drugs, didn't get the tube, used my secondary device, put a king in, get her in the back of the rig, we're rolling down the street, I forget to give my first set. She becomes conscious, not meaningful consciousness, but all of a sudden she bites down on the king airway. And she bit so hard that she completely closed off the king airway. You could not bag any oxygen past the tube. If you played with the king, you see how hard those things are? She bit so hard, it was, no air was getting in. And so I was stuck. I can't ventilate her. She's now clenched down because I didn't give my post-sedation. I did not put a bite lock in. I didn't put an OPA in. There was nothing to protect her. She was good. 5 milligrams of Versed and prayed that it worked as fast as it could. And so finally, right when we got to the hospital, it was like, it only lasted probably like 30 seconds, but it scared the shit out of me. So then we get to the hospital, and so I'm bagging her, everything was fine. I told them I gave the meds late. And then it took 2 ER docs and a anesthesiologist 45 minutes to intubate her. So I felt good that I didn't do it too. It took them a long time to do. So give your post-sedation meds, and I learned that from that experience. So, and that's how bad it can be. If you don't get your Versed and the sucks wears off, you're screwed. Of course, I could have resucked too, but that's the moral of the story. Not as exciting as Chris, I know, I'm sorry.
A little more realistic.
We need more bang.
Yeah, you need to. How much you got left? Oh, you're done too. All right. So we got our Versed in there. Okay. We can also give additional dose of fentanyl to assist. We really, like I said, we really want to try and avoid the additional paralytic dosing, because what's going to happen is when you get that patient to the hospital, the neurologist is going to want to do some sort of neuro exam. So what they're probably going to do is they're going to make an attempt to slightly let the sucks wear off, okay? Because they're going to want to do some sort of neuro. And so that's why they kind of, the long-term paralytics, like the rocuronium, the becuronium, they make it MD order now because they don't, because what we used to do is we give the sucks and then we just follow it up with a long-term paralytic. So we roll into the ER and we got a long-term paralytic that's a 45-minute duration on board. Neurologist is going to sit there and be like, dude, I got to wait 45 minutes before I can figure out what type of neuro
That's
findings.
cruel.
Yeah.
It's cruel.
So, so what we do is we just try and
Cruel?
Punishment. I mean, it's cruel and unusual. I mean, it's not ethical. I mean, she's paralyzed. She's feeling all the pain. She's, you know what I mean? Just like the baker, and that is cruel. That is really cruel.
so don't do it. Give Versed, give the fentanyl.
Give happy drugs.
Keep the way I approach it is like, dude, if I was in this situation, what would I want? Same thing with people that hurt their hips and break their legs and do that kind of stuff. It's like, what would I want? I was like, hey, I am like the candy man. Like, I give it out like there's no tomorrow. I'm just like, hey, how you doing? I'm like, no pain? How about now? Still no pain? How about now? I'm like, because I know what I'm gonna do is I'm gonna lift you up and I'm gonna move you and you're gonna have me, right? So I tend to give people a lot of pain medications,
Same here.
just because it's like, man, I feel sorry for people.
I want people to be like -2, not 0. I want
Yeah,
you to be
negative.
negative numbers. I want you to be
All
really
right,
happy.
so we're back at the 3 mics per kilo. All right, so we got post-sedation meds that we gotta drop and get ready to go. Right, we're gonna give that stuff. When are we gonna give that?
3 to 5 minutes.
Do we wait for stuff to start wearing off?
No.
How long does it take for this stuff to take effect? Once you push it in an IV?
Couple of minutes.
No.
It's
Seconds. All right. So it's okay to see the Curare clef as long as you have your meds ready to go. All right. What you don't want to be is see the Curare clef and be like, oh geez, I haven't gotten anything drawn up. I'm not ready. I'm way behind. Okay. But if you're sitting there and you got your Versed all drawn up, you're like, okay, I got my two of Versed here. I got my 3 mics of kilo of fentanyl here, and I got them all drawn up, ready to go. Then you see the Curare clef, you see the patients do a little twitch or something, and you're like, oh, okay, here we go. I'm gonna give you a little meds to keep you back down.
How do you spell like carotid D, carotid?
Curare? Let me see. Curare. All right, and I think it's got a little.
rare. Who rare?
Okay.
I think maybe it's got a little thing like that over it, maybe?
For the Versed, is it 2 milligrams or is it 0.2 milligrams?
So it is 2 milligrams.
As the
because,
maximum?
yes, because it is 0.1 milligram per kilogram.
Right. So
Right.
if you have 50 kilograms, wouldn't it be 0.1?
So if you had
It would
50
be
kilos, you would be 5 milligrams.
Okay.
We're at 25 kilograms.
Yeah, so we're at 25, so technically, if we could give the total dose, it would be 2.5 milligrams of Versed.
Right.
But
okay.
we're limited based on the
Max
pediatric
trigger dose.
dose.
Okay.
Make sense?
Yeah.
Alright, cool. So, yes.
So in the book, when you're reading over Airway, they talk about like you use a king if you're worried about messing around with someone's C-spine too much.
Alright, that's because you
so-
have crappy technique, but yes, go ahead.
Well, yeah, I was gonna say, I mean, like, my instinct is that it doesn't matter if they're not breathing, whether or not their C-spine compromised or not. But like, when
No,
would you?
because you gotta think back, if you're RSIing somebody, right, they're still alive, right?
Right, I mean, like, you wanna protect the airway over any concern over C-spine.
Right. So this is the cases where you're still gonna hold C-spine, you're still gonna do your manual stuff. You're gonna have somebody holding, doing the jaw thrust, helping you out to maintain those C-spines. Because you really are, you don't know if this person is paralyzed, you don't know what kind of neurological effects there are. And it's not that hard to intubate somebody and keep C-spine in place.
Okay, yeah, because I was gonna ask, so for
Yeah.
our 8-year-old, if we suspected
Yeah.
C-spine
No,
injury,
it's-
it's still intubated?
So intubating, like, people, it drives me crazy that people don't intubate more than they should, because everybody takes the easy route now. It's like, oh, I'm gonna throw a king in. It's like, why?
It's the easy button.
It's the easy button. Yeah.
But it's not a definitive airway.
Exactly. Like, you take a tube and you stick it into the trachea, you watch it go through the cords, you watch a little black line disappear, you know that tube is in the trachea. It's like, okay, well, I know that my tube cuts on my king tube, I'm doing some sort of passive ventilation kind of thing. Yeah, I'm getting some ventilation. Who knows, maybe the tip of my king has curled up and it's not getting a real great seal, right? Versus, I know that my tube is completely in the trachea. Absolute definitive airway. So I am a huge proponent of intubating with an ET tube versus using the king tube. I've just seen too many technical issues with the king, just poor technique with people using it, failure of the device, and so I'm a huge fan of the actual ET tube portion of it, and it's not that hard to intubate with C-spine precautions and things. All right. Okay, so let's say you are way up at like Blue Pool. Oh, no, it's too sunny for Life Flight to fly. Reach is out doing something cool and fun, and they're unavailable, so you can't fly. You guys are the paramedics. So you need to intubate, and radio doesn't work because radios never work, and your cell phone doesn't work. So you make the determination that you need to paralyze this person for the long haul because you don't have enough fentanyl, Versed, and sucks to keep this person intubated for the whole way in. You would run out. So we do carry long-term paralytics.
You move to rock around.
We do. We have rock. Do you guys carry anything other than rock? Still rock? Okay. So we have our rocuronium. Alright? So medication dose of rocuronium is, you have two different reasons. If you use it for a first line versus maintenance, would this be considered a maintenance or a first line?
Maintenance.
Already using rock, because you're saying rock is your
If
sedation.
this is our same 8-year-old patient that we are
8-year-old patient,
already,
The skateboard thing was down over the pool, down, launched off, hit rocks. I don't know, some sort of crazy.
So
weird
we use
thing.
sucks as the initial.
Yes.
So this is would be a maintenance test.
So this is your maintenance dose, right? So your maintenance dose is, I'm going to help you out with this one just because there are multiple different ones. So now we're at rock. It is 0.1 milligram to 0.2 milligram. per kilo. Make sure I got that right for you. But yeah, actually, maintenance dose, yes. 0.1, 0.2, yes.
What's our adult dose?
What's what?
Our adult dose.
Adult dose is the same.
Same.
Yep.
Um,
So how much are we gonna give?
2.5.
What's that?
2.5.
0.1 milligram per 0.2 kilograms.
0.1 to 0.2 milligram per kilo. So which one do you wanna go with?
0.2.
Go with the high dose, right?
Do we have a max dose?
There is no max dose. So 5 milligrams. Okay? So that should keep somebody under for roughly 15, 20, 30 minutes. Okay? Obviously, you're gonna have to fill out unable to talk to MD, paperwork and stuff for having the unable, because this is an MD order. Anytime you use long-term paralytics for this type of a situation, it's an MD order. Okay? But we couldn't get a hold of them, so we're gonna fill out some extra paperwork and call it a day.
So you had said that 15 to 20 minutes, but then you had said before 40 minutes.
It all just depends. So each patient, so when I say 40 minutes, there's additional long-term paralytics like becuronium that can last up to 45 minutes. And so that's just going to be a department dependent what long-term paralytic you use. So you range from anywhere from 15 to an hour in your long-term paralytics. And that's just going to depend on what your department
That's the
carries.
paralytic, not necessarily the patient.
Correct. That's the the half-life of the long-term paralytic. And that's why
We use a lot of rock on Florence because we're generally transporting the riverbed where the neurologist is. So we will use a long-acting paralytic as our primary.
And so if you're coming from Florence, that's approximately an hour, so you'll have to hit them with 3 doses.
That was rock.
probably 2, probably.
Maybe
You
two,
said
but-
15 to
But
20?
we like, again, we like to paralyze and then sedate as highly as possible.
Yeah.
We
So
carry-
you're mixing.
We carry
your
10 milligrams per
fentanyl
set.
% in with the rock as well.
Okay,
So you just
and
keep-
then at that point, are you waiting for a clef?
If I see a Curie clef, I'm gonna give more fentanyl and more percent.
But not your paralytic?
Nope.
You're
I'm
gonna
gonna
keep,
snow them. I'm gonna
Yep.
make them more happy. They'll be like, I'm not leaving them.
and so depending on how far you're going and how much meds you have left and how much meds you used before up here, it's all gonna depend on what your supply is in your rig, on what combination of meds you start to use post sedation.
If we
And that-
ever re-paralyze people, we highly sedate them.
Yes.
Okay, so just the sedation can take care of our gag reflex and our patient waking up?
Yes.
Yes.
Absolutely.
Okay, so we don't have to have them paralyzed?
Correct. And so that's why most of the
sometimes-
time this is what we do.
But sometimes the neurological reactions of people, they overpower what you're sedating them with, and then you do have to paralyze.
Okay.
Does that make sense?
So we're just
You just
trying
you're mixing
our,
that.
our cocktail for
Yes.
what we feel is necessary.
You are becoming a paramedic as we speak right now. That is the funnest thing about being a paramedic, especially like when you run a code. When you do things, you're just like, okay, this isn't working. Okay, what am I thinking? What's my thought process? I'm like, ah, let's try this. Okay, we'll do this. We'll try this, and you're making educated guesses. Really, is what you're doing. And so you make every attempt to keep somebody under with this, but it's like, okay, well, I can't give 1,000 milligrams of or 1,000
I've
micrograms
given all my
of.
Versed, I've given 10 of Versed, I gotta give them rock to hold it
Yeah.
down.
You run out of your meds.
Okay.
So at some point, I would say if you're way at McKinsey and you're an hour away, I'd be calling another medic.
Yeah, you're gonna need more
Dude,
meds.
I need your shit.
Yeah.
We need to intercept.
Yep, absolutely, and that has happened. We're like, so like organophosphate poisonings with atropine, you need tons and tons
Yeah.
of atropine. You're
10
like,
mgs?
dude, send me two additional medic units because I need more atropine.
Is there a, would like a VC be able to go to like one of the stations and just grab like a handful and just drive up there to meet you, because that's all you would need?
So most of the time, it's just gonna be like whatever the closest medic unit is,
Yeah, that's gonna be
and
the quickest.
that's gonna be the quickest route because BCs aren't even gonna know what med. They're gonna be like, hey, go give me atropine. They'll be like,
What's it look
what's
like?
atropine look like? It's like legit, like, yes, they carry like cyano kits and stuff like that. They know where this random kid is. They have no idea what this kid is, but when you call for it, they're like, yeah, here, I don't know what to do with it. It's just sitting in my rig. And so most of the time, what you're gonna want is you're gonna want that other medic unit, because what's gonna come with that other medic unit?
More paramedics.
More paramedics, right? And so if you're already struggling to keep this person under, you'd be like, dude, what do you guys think? Like, this is what I've done, this is like, I'm doing a little phone a friend thing here, I'm talking to you, like, you guys think of anything else? Am I doing anything wrong? What do you guys think, right? So the more the merrier. The more paramedics, the merrier, okay? So, we're at about an hour. Whew.
Still going.
Right? So we finally got this person
They're
rapidly,
doing RSI now?
yeah, rapidly sequence innovation.
It's fun.
So we're doing this in the ER with the docs, like, come on, are you done now? Because we're at an hour, we should be there.
Right, yeah, so that's the thing, but it's if you come from Blue Pool, so now you got.
Oh, now we're in Blue Pool.
Yeah, Blue Pool, ski motor over the thing, you had to pack them out, you're innovated from the bottom all the way out, okay?
Probably would, you probably get all the RSI intubated before you move, I imagine, too, right?
Oh, yeah, if you're in the bottom down there, yeah.
You get in the ambulance before you move, secure things and then drive away.
And granted, I'm throwing all kinds of just stupid scenario-based stuff out there just to get you guys to think of how the meds apply and how you have to think of as you're given. Okay? So, I like it more of, let's see, I don't know, MAI. MAI is what I call it. It's not RSI, it's MAI. Medication Assisted Innovation, because there's nothing fast about it, all right? So, this is something, like, you guys are gonna wanna get down, pat, get everything figured out, because all these meds you just gave, I'm gonna roll the dice on you here now. You got a 54-year-old respiratory failure, respiratory arrest-ish, breathing 2 to 3 times a minute, dialysis patient. What do you give? Oh, jeez. Yeah, see? Huh, yeah. So first thing you need to know, well, how much do they weigh? Because you got to start there, right? Because everything is weight-based, right? So they weigh 220 pounds. 100 kilos. Oh, this math is going to be awesome. This is not going to be a 53-pounder, right? Thank you. Huh. Okay.
200.
So we got a 100-kilo patient. And we're going with a 54-year-old, respiratory failure, dialysis patient.
Dialysis is going to throw us for a loop.
Dialysis throws you for a loop. So, I'm going to make it easy on you. We're not going with this dialysis patient yet. You guys aren't ready to hit that dialysis stuff quite yet. So we're going to simplify this, okay?
You
We're gonna
came in and took over for us?
Wait, they died?
What's that?
We handed off to you.
You handed off. You know what? This right here became this right here. Trauma code.
You've
We're
been
not doing
rerouted.
it. Yep. Rerouted to a BLS lift assist. Alright. Okay, so let's go with a.
Before we go, could I?
Yeah.
Our sucks and our fentanyl and Versed. Do we do our sucks because it's faster acting than our fentanyl and Versed?
So the SUX is the actual paralytic, paralyzing agent.
But then we maintain with our opiate and benzo, and we don't worry about our paralytic again. Or, well, it's our choice if we want to
Right.
run our paralytic.
If you can keep
I'm
someone
trying
sedated.
to understand why we have a paralytic if we can just sedate enough.
Because the initial
Good question.
the initial action of the innovation is a traumatic event, okay? So you usually won't be able to sedate somebody enough to be able to pass the AT tube through the cords and
And
everything.
the level for everybody is different of what level of sedation they're gonna be based on what you get. So you get that same amount to you, it's not gonna be enough for me, it's not gonna be enough for her, but it might be enough for him. You don't know.
Depends on how much we party.
Yeah.
Right.
But
I
once
had-
you're tubed, then
I got 2 milligrams of Versed for my vasectomy, and they said it was an amnesic. It's bullshit. I remember everything.
Oh, yeah.
watched the whole thing.
Dude, I had so much fun.
I
Yeah.
kept hearing about how 2 milligrams of Versed was going to be an amnesic. I remembered it.
Oh, yeah.
Now see,
So I needed at least 6 to not remember it. You know what I mean? So you don't know how much people are gonna need for them to be unconscious enough to intubate?
So cool.
So I had an injection in my back, and it was one of those steroid injections. And I walk in there, or not rock, I kind of rolled in there, and I'm laying on the bed, and the doc knew that I was a paramedic and everything. And he's like, and I hear the anesthesiologist, they're like, "Hey doc, what do you want to do?" He's like, and I've never had Versed before. I've never had fentanyl before. He goes, "Let's go 300 of fentanyl and 10 of Versed."
10.
And I go, "I like your style, doc. I like your style." And no kidding, I put my head down like that. Next thing you know, apparently I'm bailing off the table. Like, I remember nothing. Like, the whole thing took like, I don't even know how long. But I was just like, oh, hey, and I'm like bailing off the table, I'm ready to go. I didn't remember a single thing. I was just like, so then I had it done a second time. I roll in there, and I hear the same kind of thing. And he's like, well, I go, last time it was 310. He's like, let's do it again. I'm like, party. Same thing, boom. And I totally don't remember a single thing of the entire event. It was just like, I'm just like, oh, I'm glad I didn't try and sit up in the middle of you having a needle in my back. But it's that kind of thing. It's like each person is going to react differently. Like, I don't know if they tried to intubate me. Who knows? I don't know what they tried to do to me while I was on this. Because I don't remember a thing. All right? But with the sucks, it puts you completely, there's no question
That's
about
the
it.
equalizer.
Yep.
Sucks is the equalizer.
Sucks is
for
the equalizer.
everybody.
It eliminates everything, eliminates all muscular tone. So some people you can sedate, but their muscular tone is still there. Sphincters are still intact. Gag reflexes are still intact. With the sucks, it just eliminates everything, and it makes it simple. You go in, you do your intubation, and then you can help maintain. And it may be you can't keep them under with this, right? Because there's not enough. You don't have the right combination. The person reacts differently to it. And you come back and you have to redose the sucks then. Because you know the sucks work to get them under.
But if we have to redose with sucks, we're thinking rock.
Just depends on where you're at.
Where you're at, how
Far out I am.
Right.
And
Okay.
who your MD is.
And what?
and who your MD is.
Okay.
Yeah. Yeah. Okay. So, oh man. So how you guys doing on RSI?
Okay, wait, I have a question.
Oh.
And I know it's gonna be a dumb one, so.
There's no.
Not dumb
Well, I would
questions.
say there's no dumb question, but I have
There-
heard some pretty doozies out
There's
of students.
dumb questions. Why
Oh,
do we
erase
need
that.
to
I
know,
want to take a picture.
Oh, sorry.
why?
I was gonna start a whole new scenario here, and I was gonna say, you
Wait,
guys.
Mark, are you videoing me? Okay, you can erase it.
You can't really read it on the video.
All right, you want to take pictures? Whoever wants to take pictures, you can go ahead and take pictures.
Never mind, erase it.
We're still focused on you.
I got it.
I'm listening. I'm sorry. I got
Why
squirrels
do we
over
need to
here.
know the concentration of the drug when really what we need to know is how it's packaged?
Does
Do you understand what I'm
packaging
saying? It's like, it
Yeah.
is
Because
very
what I'm having you do now is I'm having you just do the simple math. That is not so simple when you're stressed, because it is going to be different based on concentrations and stuff. But what I'm doing is I'm throwing out. It's like, okay, well, it's packaged this way. Tell me what the dose is going to be. How many milliliters are you going to give? Because you're going to have to come up with a calculation somehow to do that milligrams to milliliters calculation.
Like,
No, but this
lidocaine
seems
and,
excessively hard. Like, why are we worried about micrograms when really we just need to know how many milliliters that is?
Because you have to
You
be
know
able to
what I'm saying?
you have to be able to figure out how to get it from the micrograms to the milliliters.
Because it comes in different packaging.
yeah.
The dosage is the same.
So this math right here that we just did is gonna happen on every single RSI that you do. You're gonna have to come up with this kind of math. And you'll see when we start playing with the meds and we hand you a vial of ketamine, it'll say on there 200 milligrams per 5 milliliters. Okay, great. You need to give 125 milligrams. How many milliliters do you drop into your syringe? With the screaming combative patient screaming at you.
Right.
So that's where you have to be able to take that and be like, okay, I need to get that.
So I would say, first and foremost, learn your dose per patient. It's 1.5 milligrams per kilogram. That's, all of those doses, memorize those. But know that each one of those drugs is gonna come in a different concentration. And eventually you're gonna have to transpose what your dose is to how much you pull out of that vial.
We still haven't gotten told that.
Yeah, we still haven't gotten told our specific paramedic doses. All we've done is just looked up like broad general medical
So that's
doses.
why I'm throwing these doses at you, because these are the doses that you guys are gonna be quizzed on every time I see you in lecture from this point forward.
Yep.
This is Lake County Protocol.
This is Lake County Protocol. I know it's not the Bible or anything like that, but this is gonna get all of you a general direction for RSI, because RSI is the thing that you have to be the quickest thought math. This is the hardest math thing that you're probably gonna do, other than dopamine. We're not even gonna touch dopamine tonight, all right? But this math calculation right here, it's all gonna become second nature to you. Because I'm gonna simplify things as we go for you.
So as you train this, like when, you know, we're at home having your life, it's
Right,
memorize.
welcome to becoming a paramedic, yes.
It's memorize, dose, throw out a kilogram to get your actual dose.
Correct.
And then someone could give you random McGee, like milliliters to whatever ratio, because
That's how it's packaged that
that's
way.
how it's packaged.
Yep,
And then you convert from your dose, which is including their weight,
yep,
which is converted to kilograms.
yep. Yes, you're getting it.
I quit.
Well,
Okay.
welcome to being a paramedic, okay? So, I know this seems really stressful, and there's a lot of drugs and a lot of medications here, but we're gonna start simplifying things, because we only have like probably 30 drugs that we give, really,
That you need to know.
that you need to know inside and out. And that's gonna be a straight up memorization, okay? I know you guys are memorizing a ton of other stuff, but what you gotta do is you gotta get ahead of these kinds of things, because this is where people will struggle, is this math, okay?
And this is why there's a lot of paramedics around the country that aren't allowed to do RSI.
And isn't
Correct.
most of the math that we're gonna be doing, like the 53 pounds, gonna be rounding anyway, because it's so menial? Like, I don't know. It seems like, because.
So, do you remember what I said here at the very, very beginning? What do I like to do to make things easy?
Round to zero.
Round to the zero.
Yeah.
So, 30 kilo, 20 kilo. So me, for real life, I'm gonna round this all the way up to the 30,
Yeah.
okay? And so so all my math becomes 3.
Sorry, Doc, I estimated them at 30 kilos. I didn't know they would be 25.
So do you round up or down?
What's that?
Round down.
No,
So you always round
How
up
much
because
do
you
it?
don't
How
want
much
to
do I weigh?
under paralyze.
So if somebody's
It's all
done
guess-
50
it's
pounds,
all estimating.
you'll run up to 300 pounds?
No. So you always go to kilos, so round to kilo
Because that
first.
would be- I mean, like,
and then round
So
because
75,
the 30 kilos
80,
to
80
pounds is 66 pounds anyway, to where that's like 10 pounds difference.
Right.
Which isn't very much.
That is, yeah, not a huge deal, right?
So,
Because
Okay.
if I look at Derek, can I be off by 10 pounds?
Yeah.
Maybe 20 or 30.
I know, I'm off.
Right? So everything is an estimate, and so, I mean, I know it's not fun to walk
How
around
much and does
be like,
Chris
hey.
weigh right now? How much does Chris weigh?
165.
So see, oh, boom, so you guys,
That's how much I
so
weigh.
this is what I'm talking about. You're taking away part of my fun. Gosh, dang it, Derek. So just so you guys know, Derek's not allowed to be in lecture ever again,
Damn it.
okay? So this is part of what I'm gonna do to you guys. When we start these lectures from now on, they're gonna be like, all right, hey, Andrew's your patient. I want everybody to write down, Andrew's your patient, write down how much he weighs in kilos, go. Write it down, write it down, here we go, write it down, I want everybody to write down a number. Andrew is right here, just in case anybody doesn't know who Andrew is, Andrew's right here. Okay,
80
no.
kilos.
How much does he weigh?
Wait,
Write it down, I want everybody writing it down.
90
Kilos
kilos.
or pounds?
Kilos, because everything we do is in kilos, okay?
90.
I know what I'm going with.
80.
You can't say your stuff out loud and give everybody else the.
The answer? The right answer?
Alright, everybody done?
Time's up.
Okay, how many people have him at 60 kilos? How many people have him at 70? Oh, I saw it, see? Boom, it's okay. It's alright, we got a 70. How many people got him at 75? Oh, we got 2 at 75. How many people got him at 80? Do we got an 80? Do we have an 85? If I got an 85, oh, do we have a 90? We got some 90s. We got 90 kilos. Holy, do we have any 95s? 95 kilos. Anybody, 95 kilos? No? All right. How about 100 kilos?
Anybody higher than that?
All right, so we had, geez Louise. So we had somebody at 75, right? We had a 75? Up to 80? 90. Up to 90. What's the difference in kilos between 75 and 90 kilos?
Like 30 to 40 pounds.
15 to 30 pounds, 33.
So we got 15 kilos, so 30-pound difference, right? Ish. like you can eliminate the 0.2, the 10% of it, right? So 30 to 33 pounds-ish difference. So you guys are 33 pounds away from each other, because it's all an estimate. Everybody has a different way of approaching. So Andrew, if you don't feel uncomfortable, how much do you weigh?
I weigh $185.
$185.
Oh.
So,
Oh.
cool. How many kilos is that?
Almost 200.
About
80
85 is 82
or
kilograms.
pounds.
Boy, I mean, this is the simple part of the math. So how many kilos does Andrew weigh?
87.
87. He weighs 87 kilos. So how are we going to make that easy for us?
90.
Boom, we're going 90. So Andrew gets tagged with the 90 kilo, right? Because we always go a little higher, right? Because it's all an estimate anyways. So anyone that was, how many people were under 90? 90 or not the 90, but under 90.
You just kept me awake during that.
I was gonna say, just so you know, Andrew remembers your name. He knows exactly where you live. He knows your badge number. He knows everything about you because you were joking around and trying to set everything up.
You should stop faking it.
Right. Okay? So all of you under-medicated Andrew because it was an estimate, right?
But if you under-medicate him, can't you just more medicate
Well,
him?
how are you gonna know if you under-medicated him
Yeah.
like
The
a couple hours later? So
Says he's
you
coming out of
can,
it.
so you can put somebody under to the point where they're under enough. They're not gonna fight it, but they got enough wits with them that they can hear what's going on around them. Andrew is pissed at you right now, just so you know. He doesn't like you guys because he was totally awake during half of that. Okay? So that's the kind of thing where the estimation of your math, it becomes an estimate. So now you got your 90. So boom, now you're gonna start running through some of your stuff, right? So what's 90 times 1.5?
135.
135. What's 3 times 9?
270.
27.
Simple math, we're simplifying, right?
27.
9 times 3, 27. So 270 mics. And how about for, we got atomidated at 0.3 milligrams per kilo. What is 3 times 9 again?
27.
So now we're 27 milligrams.
30 with 27.
All right, and we got our ketamine was at 2 milligrams per kilo. 9 times 2.
18.
So we got 180. Oh man, we're down to sucks. Here we go. How much is sucks? 2 milligrams per kilo.
180.
180 again. Oh man. Okay, and now we're at percent.
97
6.
0.1 times 9.
27 micrograms.
170
micrograms.
Nope.
6 milligrams.
But I just asked what's 0.1 times 9.
9.
9. So we're 9 milligrams, right?
No.
No.
But your max
Six.
dose is 6.
Lower 6. Okay, so we're gonna go 6. All right. So you see how much easier that was that time around by simplifying your numbers. I didn't even get to milliliters yet. All right. So we didn't even calculate into that. But what we were able to do is we were able to quickly come up with the milligrams, right? So the milligrams part of it is the easy part.
The milligrams, micrograms, whatever.
Milligrams, micrograms, yes, kilograms, you know, grams, all that stuff, right? So getting the milligrams, we try and make easy for you guys because the hard part is taking it from the milligrams into the milliliters. Because you'll have to pull up syringes in milliliters, and you have to do the math that takes it from milligrams and turns it into milliliters. And this is where I take your calculators away and I start screaming at you while you're trying to do the math. If you ask people from last year's class, it was hysterical the first time I started screaming at them as they're doing the math. They didn't know what was going on because I was a hysterical family member. Nobody decided to calm the parents down. They just were dealing with the kid, okay? So you're trying to do the math, you're stressed out, and so we try and simplify things for you so that at least half of the math becomes easy. All right? Does that make sense? Are you guys totally overwhelmed now?
Can we go over those doses one more time, just so we're all on the same page?
We can absolutely
Wait,
go
here's
over.
the trick. Watch this.
Stop.
Go do it.
No, not
So,
Are you going twos? Rule of twos?
no,
Okay.
yeah, well, kind of.
Yeah.
So you figured out your first dose, right? 1.5 times 90 kilograms is what? 135, right? Take that and times it by 2, you get 270. 10% of that, because it's 0.3, is 27 milligrams. Did I just blow your minds? right? Because you're looking at, you're looking at threes, right? So 1.5, 3.3, right? So you figure out the first dose, 135 times 2 is 270, and I'm gonna go 10% of that, which is 27 for my etomidate.
Boom.
Ah. See? So you start to learn shortcuts as we start doing this stuff. Yeah.
So it
5 plus
says
5 is 2, 3, 6, 9, 24. 32.
Divided by?
Remainder 4.
ICP, what is that? Yeah, so how does that tie in? Like,
How does
are
that-
some of these only for
Yes.
ICP?
Lidocaine and fentanyl are only for
Yes.
pre-medication. So this right here, your 0 to 3 minutes pre-medication, that is for intracranial pressure, those 2 medications only. If you do not have head injury, so this person right here, 70-year-old respiratory distress patient, non-head injury, right? So you automatically just simplify, skip those. Okay? So if we have respiratory distress with COPD, we already know ketamine because we got a respiratory disease. So we already know we start with ketamine. Okay? So Derek's your patient. Derek is our 75-year-old respiratory distress COPD patient. He's gonna stroll across in front of you. You get to estimate how much ketamine you're gonna give him. Go. 5,
250.
4,
250
3,
pounds.
2, 1, 0. Boom. All right, have a seat. Okay. Don't say anything out loud. Everybody figure out your kilo. Figure it out. We're gonna see what kind of range we come up with. We're gonna see what kind of range. Can we bring it in a little bit? We were at a little bit of a spectrum here. All right, has everybody got their numbers?
Yeah.
All right, how many people think Derek's 60 kilos?
Wow.
Dude, I totally would have went 60 or
Maybe when I was 13.
Let's go 70. 80. 90. 100.
You guys are generous.
No kidding. Okay. 110. 120.
Now you're cruel.
130. Hold on, we're not done yet. 130. 140. 150. Okay, so 110 was the top?
120.
120. So we got 120. And what was the low?
100.
100.
I mean, I was thinking 110, but it sounded like it's
Well, it
better
doesn't
to
matter.
s-
You're right in the middle, so it doesn't really matter.
Well, no, I said 120, but then it was like it's better to snow them, so I went with 120.
Okay. I get your reasoning. So what are the pound difference between 100 kilos and 120 kilos?
220 to 250.
220 to 250. So once again,
It's a pretty big spread.
30-pound difference.
It's like Thanksgiving.
Whew, that's like one meal at Thanksgiving. Okay, so big difference in range. Derek, how much do you weigh, if you don't
So
mind?
2 weeks ago, I weighed 250. I weighed myself yesterday, and I'm down to 242.
Nice.
Alright. We're still gonna do the math at 250.
So 242, so how many kilos is that?
No carbs.
242. 242 pounds, how many kilos?
120.
250 is easier math.
130.
What do we got? I'm
No
hearing
carbs,
three
I stopped
different
drinking.
numbers. 132.333.463. No, how many kilos?
120.
110.
Just so you know, this is the easy part of the math.
110.
110. I got 109.09.
109.09. Ha, nobody wants to do that math. Everybody wants to do the 110, right? Is 110 close enough for a roundup for us?
Yes.
Yeah, we don't need to round anything more than 110. 110, we're just going just whatever the next 0 mark is for it, all right? So we're at the 110 mark, so let's do some quick math. We're at 110 kilos, here we go. 1.5 milligrams per kilo. Oh man, that was not quite so easy, because now it's not just a 1 plus 1 plus 2.
165. 165.
So we need 165 milligrams, huh?
Yeah, I
Take
think
that times it by 2. What do you got?
330?
330.
Uh-oh.
More fentanyl than you carry.
And then 33.
330, what's the max dose of fentanyl? No. Good try though. So normally fentanyl for pain management, max dose is 300. RSI, there's no max dose of fentanyl.
Oh my
But just so you know, giving somebody 330 at a time, you're gonna run out of fentanyl pretty quick. So just a heads up with that. So this would be one of those cases, Derek would burn through your fentanyl for your post-sedation stuff pretty quick, okay? Yeah.
I thought we didn't have an ICP, so we don't get fentanyl.
We were just running,
We're just
Oh.
running,
Just
through all the drugs.
we're just running through all the math. But yes, excellent
Yes.
catch. Yes, normally Derek would not hit either one of those, but we're just running through doing some math.
Wait, so do you not pre-medicate at all if there's no increased ICP?
Correct. So your pre-medication is the etomidate and the ketamine. This is
Or
one of those. Your
So you
sedation
do
med.
pre-
You start with your sedation med. So when we say pre-medicate, you have ICP pre-medicate, increased intracranial pressure pre-medicate, and then you have pre-paralytic medication. Okay?
I think they
So,
call it induction.
yeah, so ICP meds, lidocaine and fentanyl, induction meds, etomidate and ketamine. Okay?
Paralytic sex.
And then paralytic medication. Okay?
So if you're at that range, would you just give lidocaine? If you were given an ICP and you had that number and not give the fentanyl?
No, you double them up. Give them both.
Don't be a dick.
Yeah, dude. What? Okay, so for the record, nobody called Dustin 911. He's not gonna give you all the good stuff.
That's
He's
why I
only
asked the
gonna give you
question.
something that's really effective.
Why does ICP have more stuff? Like why?
Because what you're trying to do is you're trying to sedate to the point where, so when you start to intubate people, you start, what sort of reflexes are you affecting?
You're getting a vagal response.
You're getting vagal responses, you're gonna get an increase in intracranial pressure based on different gag reflex stimulation, okay? So you're gonna end up having, you're trying to reduce that prior to your paralytics being given.